We're back with another episode of the Skinfluence Podcast. I'm your host, Dr. Dustin Portela, board-certified dermatologist.
And I'm Austin. I'm a physician assistant who's been practicing derm for, feels like longer than I should be, but
yeah,
10
actually
years.
Longer than me.
Yeah.
So.
Yeah, I don't feel old.
No, you're younger than me. You shouldn't feel old. So today we're going to be talking about one of the most common procedures that we do in the dermatology office, a procedure that might invoke some fear when you're coming in to an office, and that is a biopsy.
Yes, this episode is perfect for anybody that you know who is avoiding the dermatology office visit because they're scared we may perform a biopsy.
Yeah. And we always have a biopsy tray set up in every room.
Yeah.
On a Mayo stand. And sometimes people come into the room like, what is that for? Like, are you? And it's just always there because it makes our workflow better. But just because it's there doesn't mean you're getting a biopsy on your visit.
Yeah, no.
So,
but
I think the first thing people need to understand is why we do biopsies. What is the purpose of a biopsy?
So the purpose of a biopsy is simply to find out if something on their skin is concerning or not, or to determine what exactly is going on with their skin.
Right.
So when we find a lesion that we suspect is skin cancer, we will usually perform a biopsy on that. Now, it doesn't mean that just because we're doing a biopsy means it's going to be skin cancer. Mm-hmm. It just simply means that we have a very high suspicion for it and we want to be 100% positive it is or isn't, and then we can make those appropriate decisions after.
Yeah. Essentially, it's a diagnostic test. We're trying to get a result that will help us make better decisions for the care of the patient. It could be that we don't know exactly what a rash is, and we're going to try to find out what a rash is. It could be, is it cancerous? Is it not cancerous? In some cases, we may look at a biopsy as a treatment modality.
Sure.
If the intention is to completely remove a lesion, but then technically it's not a biopsy. It's considered like a shave removal or something.
Yeah.
But sometimes we will make an attempt to completely remove a lesion, but most of the time it is simply to get diagnostic help to improve the care of the patient.
Exactly right.
So, and biopsies are not just limited to dermatology, obviously. Ear, nose, and throat doctors might biopsy a thyroid. Breast cancer surgeons might biopsy a lesion on the breast. They might biopsy the lung. I mean, just any tissue in the body can be biopsied by the right specialty.
Yeah.
And it's usually to figure out what is this thing and then what are we going to do about it. So a biopsy should change the treatment plan in some way. And there's times where I'm sitting across from a patient and they'll say, do we need a biopsy on this rash? And I say, we can, but the treatment plan for either of the two things that it could be is going to be the same. So let's not give you a scar and the expense. So
totally. And on the opposite side of that coin, I've been in situations where I have a patient who has a lesion they're concerned about. Looking at it, I know it's benign. It's not concerning to me in any way, shape, or form. But either they express or I can sense in them that this is a really concerning lesion to them. Mm-hmm. And very often, and I'll discuss this with them, I'll say, would you feel better if we just simply performed a biopsy, even though I may not think it's concerning? Mm-hmm. And if they say yes, I'll happily do that for them because it is, as we'll discuss later, a fairly simple procedure.
Right. There's different types of biopsies we do in dermatology. The bulk of the type of biopsies that we do is what is called a shave biopsy. Mm-hmm.
Shave biopsies are kind of the bread and butter of dermatology. A shave biopsy is a very, very simple procedure. What we do when we are trying to determine most skin cancers is the shave biopsy. Do I want to go into shave biopsy or I want to just list the biopsies for now?
I think we can go into it.
Okay.
I think we'll cover some of the other stuff like how we prepare anesthesia. So, I mean, you can talk about like numbing them up and stuff.
Okay. So what a shave biopsy entails is it takes 2 minutes to do, where we numb the patient. We usually use something with lidocaine, epinephrine in it, and often it's buffered so it doesn't sting as much. The patient feels the pinch of the needle and then maybe a little bit of burning for a few seconds, and then they are numb. Mm-hmm. And after that, they should not feel anything after that. And then we take a little blade. It looks like a straight edge blade you'd put into like a razor.
It is a safety razor.
Yep.
Yeah.
And then we just very superficially will shave off the lesion in question. I explain to my patients, it's more superficial than if you fell and scraped your elbow on cement. It's like that. There's not a lot of restrictions afterwards. We will shave that off. We'll do some sort of cautery, whether it's chemical cautery with, like, we use trichloroacetic acid. Some people use Drysol. Sometimes we'll have to use electro cautery if it's bleeding a little bit more. And then we put Vaseline in a Band-Aid and you're on your way.
Right. Shave biopsies are quite a quick procedure, as you mentioned. And I take that safety blade, I break it in half, so I only use half of it.
Yeah.
And generally we're taking whatever the bump is protruding from the skin and just making it flush with the surrounding skin.
Exactly.
Sometimes patients will ask, well, can't you just take it all? And in some cases we may try, if it's a pedunculated thing, like a skin tag that's growing up, we'll try to get the whole thing off. But we generally don't know what's below the skin. Does it have deep roots to it? And that's why a shave biopsy is not a final treatment for the concern. It's just a tool for getting a diagnosis.
100% right.
The second type of biopsy we might do is a punch biopsy.
Correct.
And I like to describe these to patients as like the human cookie cutter.
Yep, that's
but
what I do too.
They come in different sizes. And so if you're in the office with me, I might tell my medical assistant, let's do a 3-punch, a 4-punch, a 5-punch, a 6-punch. And that's the size of the punch in millimeters. And so it literally is a circular razor blade with a handle that's kind of like a tiny cookie cutter that might be 3 or 4 millimeters in width. So it's a very small incision to the skin using a punch tool. And then we're going through the top layer of skin, the epidermis, and generally we're trying to get all the way through the dermis into the fat. And usually it requires a stitch to close that small hole and stop any bleeding.
Yeah.
A punch biopsy can be advantageous when we're biopsying a rash.
Right.
Because a skin cancer often grows in the top layer of skin, and so we just want to get the diagnosis. But a rash might have a component in the top layer of the skin, but it might have some stuff going on in the deeper layers of the skin too. So doing a small punch biopsy allows the pathologist who looks at that specimen under the microscope to see what's going on in all layers of the skin.
Right.
We'll often do punch biopsies as well to determine the type of hair loss a patient has, because we can get down and get an entire hair follicle out of that so they can see if there's inflammation or scarring going on the scalp. So punch biopsies take just a little bit more time because we are going to put a stitch in most cases. However, they still go pretty quick, and we can do that in under 5 minutes.
Yeah. Very straightforward. And the numbing is the same process. It's just we numb it quick and easy. And then you're right, a stitch, usually have to come back a couple weeks later to get that stitch out. But then often because we're looking for a rash or something like that, when they come back, we'll have a report ready for them to discuss, hey, this is exactly what's going on. And then we can treat them from there.
Yeah.
The last type of biopsy that there's two others that we can do. One is more common than the other, but an excisional biopsy. The only time I've really ever performed that is when I have a very high suspicion for like a melanoma, and we want to do an excisional biopsy to really assess the depth because it looks like it's been there for a long time, maybe nodular, maybe more aggressive type, and we don't want to just slice through it in the skin. We need to assess how aggressive that is.
Yeah. So an excisional biopsy has the intention of removing the entire lesion. We're not just taking a sample and then leaving part of it in the skin. And I've had this where there's a large growth just below the skin. I don't know, is it a melanoma? Is it some weird cyst? Is it, but it's generally, we're doing an excisional biopsy because we're very concerned about it.
Yeah.
And the other time that I've done excisional biopsies is when a patient has a history of, I say, I want to biopsy this mole. And they'll say, every mole I ever have biopsied comes back bad.
Yes.
Can we just schedule the excision now so I don't have to do extra visits? And in that case, we'll say, yeah, because the patient knows and we know it's likely going to need more work. So we just schedule that procedure. They come back, we cut it out all the way around, getting underneath, and then we stitch it up.
Yep.
So the intention is to remove the entire lesion.
And sometimes to prevent as many visits as possible.
And then similar to that is something called an incisional biopsy. And the procedure is largely the same, but the intention of an incisional biopsy is not to get the entire lesion out. It's that there's something going on. Maybe it's quite large, and cutting the whole thing out is not practical. So we want to get a good representative sample. So we'll do an excision that will require stitches of a good portion of the spot and then decide what we need to do to treat. This is not something that I do. I couldn't even tell you the last time I did an incisional biopsy.
Yeah. The only time I've ever done an incisional biopsy was when someone had an incredibly large mole they want to removed, and we did it in stages. So we did kind of an incisional type removal, but that's the only time I've ever done that.
Right.
It's uncommon.
So by and large, if you're going to get a biopsy in a dermatology office, it's going to be a shave or a punch. The others are not necessarily done commonly when it's for diagnostic purposes. We do lots of excisions after we know what the diagnosis is, and that's not considered a biopsy. That's a treatment.
Right.
So you've already kind of alluded to how we prepare for a biopsy. We always clean the skin.
Yep.
Shave biopsies, actually there's data to show that the infection rate is not higher whether you use alcohol on the skin before or not, because it's such a small superficial wound. But in general, we often cleanse the skin. We'll then numb it up with lidocaine and epinephrine. And then once we confirm that the patient's numb, we perform the biopsy that we had talked to the patient about. So then it's kind of a mystery to patients what happens after the biopsy.
Yeah.
Where does your tissue go, and how do we get a diagnosis?
Yeah. What typically will happen is that specimen, it's in a container with formalin or some other preservative in it to keep that specimen healthy, and that way it takes, and then it gets mailed to a pathologist. I've worked in clinics where our pathologist is 3 hours away.
Yeah.
Fortunately, we have a really good pathologist here in our own valley, but that specimen then gets mailed off to a pathologist. A pathologist is then going to prepare that specimen. There's different ways to do that depending on whether it's a punch or whether it's a shave or if it's an excisional biopsy. But they'll prepare that specimen, and then they do different stains depending on what our differential diagnosis is.
Yeah.
And then they will assess it under the microscope. The pathologist then creates a diagnosis, and then they send that back to us, usually electronically.
Yeah, it's really interesting. And I think one of these days I need to go do a tour of the pathology lab for YouTube just to show patients everything that happens.
Yeah,
because I've personally toured pathology labs before, but I've never showed that on social media. But you have the biopsy in a bottle, and depending on the size of the tissue, it needs to sit in formalin for a certain amount of time.
Yeah.
If it's a very small biopsy, it doesn't take long for the formalin to completely penetrate the tissue. But if we're cutting out a really big piece, that needs to sometimes sit in formalin for 12 to 24 hours before they can start processing it.
Right.
And then they do a procedure called grossing, where a technician will take the tissue and will cut it just with a scalpel into smaller sections, and then they embed that in a little block of paraffin wax. And it has to sit in wax for enough time for the wax to penetrate through everything. And then they take it and they put it on what's called a microtome, and they slice it super thin, like thousandths of a millimeter in thickness. And they pick that up and they put it on the microscope slide, and then they run it most commonly through what we call an H&E stain, or hematoxylin and eosin, which highlights the cell walls and certain structures in the cell like the nuclei. And the pathologist is just an expert in pattern recognition.
Yeah.
They have seen what all of the diseases are supposed to look like, and then they compare in their knowledge bank what this looks like. Yeah, this looks like a basal cell. I've seen millions of those.
Yep.
This looks like a melanoma, or I'm concerned about this, I'm not sure what's going on. They may then go back to that paraffin block, take a few more pieces, and then say, I want to order a special stain. So instead of hematoxylin and eosin, they might put it through something called SOX10 or HMB45. And these are all just different chemicals that the laboratories have figured out will stain different parts of a cell.
In different colors.
Or certain proteins that the cell makes, because some cancers might produce a ton of a certain type of protein. And so if you're worried about a melanoma and you do a SOX10 or an HMB45, and then all of a sudden you look and all right, normal melanocytes should have just a little bit of this color. Yeah. And all of a sudden these melanocytes have a ton of that color. You're like, they're not behaving normally. This is a melanoma.
Yeah.
And a pathologist is a physician. They went to medical school. They trained in pathology and then specialized in dermatopathology, or they trained in dermatology first and then specialized in dermatopathology. And so you do get another bill from the pathology lab. And it can get expensive sometimes if they have to do a lot of special stains, because they charge for each one of those, and some of them are pretty expensive. But they're such an expert. I value the relationship with our pathologists so much, because I couldn't do my job effectively without the work that the pathologist does and their team.
There's a saying in dermatology that you're only as good as your pathologist. And it's so true. I am grateful to have a good pathologist so close by, and we do have, our office has a great relationship with him, and we can text back and forth questions, get more context, and it really helps to have a good pathologist on your team, because that you can help diagnose some complex things sometimes.
Right, absolutely. They always send us a report back. I mean, we have our electronic medical records hooked up with their system, so they get automatically imported. And the advantage of having a local pathologist is they pick up our specimens every night. We're not dropping them in the mail or FedEx. And if it's a simple diagnosis, sometimes I'm getting the results back the very next day.
I am too. It's quite fantastic.
It's common for it to take 5 to 10 business days in most cases. And I always tell patients, they're usually back in about a week. And then patients are pleasantly surprised if we can let them know the very next day that, hey, this is benign, or hey, this did turn out to be cancer. Let's get you treated as soon as possible. So
another thing that is always kind of enjoyable with the pathology side of things is when we get a report, they will send a picture of the diagnosis of the cells, like after you'd explain where they had sliced it, what they're seeing under the microscope. And often they're beautiful. They're quite, it sounds weird, but like basal cell carcinoma can look really interesting.
Right.
And they have really beautiful patterns, and they look like it's just one of those things where nature is beauty, and seeing the different types of cells and things like that can be quite interesting. So if you do get a biopsy done and you want to see what it looks like, you can ask us, and we will show you your pathology report with the photo.
Now, most pathologists don't include a photo, but I love that ours does.
I do
He's
too.
got a camera hooked up to the microscope. So whatever he sees, he takes a picture of, it gets imported on that. And it helps to keep me fresh, because I had to learn a lot of dermatopathology in residency. About a third of my boards were actually just diagnosing what's on a microscope slide. And we had a microscope and we had slides. Now they do it all digitally, but we had to look and then come up with the diagnosis. And so I can read the diagnosis, then be like, okay, yes, that looks like what I think it looks like. And then it just helps me to remember what it looks like, because I have to do continuing education. And it's like a little CME every day when I sign off my pathology. And I agree with you that I think sometimes it's beautiful, like a fibroepithelioma of pincus. Is like one of the coolest things under a microscope. And I like it so much that in our satellite clinic, all of the artwork on the wall is watercolor paintings of histology slides. And it looks cool.
I like them. It's good art.
So I think it's important just to know that just because a dermatologist is recommending a biopsy, still be reassured. One, it tells you they're trying to get more information. It's not a guarantee that you're going to have a skin cancer. My hit rate is pretty good. So if I think something's a cancer, oftentimes it is. And so if I'm doing a biopsy, I have a high degree of certainty that probably is, but it doesn't mean that 100% are. And be grateful when something's not cancerous. And I understand it can be frustrating if you now have a scar that people can see and it didn't even turn out to be cancer. But this is something that's always perplexed me, is if you had to go and do a lung biopsy or a breast biopsy or a prostate biopsy, and they then called you and told you, turns out it was benign, like, you're so grateful. You're happy. I don't know that anybody's like, I shouldn't have even done that. It turned out to be fine. But it does happen on the skin. And we are mindful of the cosmetic outcome when we're taking a biopsy. We're not trying to take the biggest chunk, but we have to make sure we get enough that's helpful for the pathologist to give us an accurate diagnosis. There's
definitely been a reputation in dermatology where providers are just like hack and slash, and every time you come in, they get a biopsy. But if you have a good rapport with your provider and you know your provider is there really to help you, a biopsy is just helping the provider to make sure that you're being taken care of in the best way possible.
Yeah. And I would also say, if you are seeing a provider who's routinely doing skin biopsies and they're not a dermatologist, you're in the wrong place.
You're in the wrong place. Or if you're getting biopsied again and again and again, and every time they're benign, then
it'd be good to get a second opinion.
Good to get a second opinion.
So that kind of covers the ins and outs of a biopsy. I've got a little trivia for you. What do you got for me today, Austin?
So my Did You Know is all about pathology, but even though that a biopsy is usually around the size of a pencil eraser, the information that's given under the microscope can show hundreds, if not thousands, of different details that provide the pathologist with information about what's going on with that patient's skin.
It's really a fascinating field. I enjoyed my pathology rotations. I just like people so much I couldn't sit behind a microscope all the time.
Yeah.
But it really is an interesting field to be in dermatopathology or other types of pathology as well.
Yeah.
And they're such an important part of the medical system.
Yeah.
In all fields.
Yeah, they're essential in ours for sure.
So, mine is that a busy dermatopathologist will often review over 100 cases a day. And that is a ton. I mean, if you think about any regular doctor seeing 100 patients in a day, I mean, there's dermatologists out there that do, and they work long hours.
Yeah.
But to review 100 cases a day is a lot of work. It is very mentally taxing.
Yeah.
But I've known some dermatopathologists that might even 200, 300 a day. They're working long hours. But it's something where they can get through a lot of cases, a lot of patients, but they have to be able to make really important decisions.
Yeah.
And when it comes to diagnosing a cancer, especially a melanoma or a Merkel cell, there's a lot of pressure on them. And so
I'd imagine.
They have an important job, but they work hard for what they do.
The patient's lives that they're looking at are essentially in their hands. If they misdiagnose something, that could affect that patient forever. Well, let's talk about what happens after the biopsy is performed.
Yeah.
So, patient comes in, has a biopsy performed. What does post-care look like? What can they expect? What do you usually tell your patients?
So, in almost every case, we will put a little bit of Vaseline, like plain petrolatum, petroleum jelly, right on the biopsy site after we've stopped the bleeding.
Yep.
And usually cover it with a Band-Aid that's appropriate for the size. If it's a small thing on the nose or the upper lip, it's a small Band-Aid. Most other places, it's a regular Band-Aid. If it's on the lower leg and it wants to keep bleeding, we might do a pressure bandage, but there's usually Vaseline first. Sometimes we'll do mupirocin or gentamicin and antibiotic ointment, never Neosporin.
Never Neosporin.
Just depending on certain unique situations. And then we usually instruct the patients to keep that bandage on for 24 to 48 hours before they remove it, wash the area, and then basically they don't have to keep it covered.
Yeah.
They just need to keep a little Vaseline or Aquaphor or something on there.
Yeah.
Because the cells will migrate over and heal faster if you keep it moist.
Yeah. I typically tell my patients where we're doing biopsies on their face, leave the Band-Aid on till later today or tomorrow, and then just a thin layer of Vaseline should do a good job for you.
Yeah.
When a patient has a biopsy performed and they're concerned about infection, things like that, when is a good time to call, or how should they be reassured?
We get calls on this, not infrequently, where there's going to be a little bit of redness around the biopsy. Just like any cut or scrape, you're going to have a little redness because the body's trying to heal it. It's bringing in the immune system. And you have a little open scab there, a little open sore. And it's usually going to fill in with a white material called fibrin.
Yep.
And that is the body just laying down a matrix or a scaffolding so that the cells can kind of crawl through there and connect to each other once again. But oftentimes people will confuse that fibrin or fibrinous exudate with pus.
Right.
And they think they're infected. Like, it's a little red. I see some white stuff in the middle. All right, send me a picture. Yeah. It's totally fine. It looks exactly how it should at this point.
Yep, that's exactly right. Very, very often we get people taking pictures and emailing them to the office saying, is this white pus okay? Do I need an antibiotic? And we say that is exactly how we like it. Now, if it's oozing pus, if you have this white material dripping out around it, okay, maybe we're infected. We need to get an antibiotic. But
if the redness gets bigger day by day, I mean, you're going to have a small ring of redness around a biopsy, but if it grows day by day, your pain is increasing day by day. You have red streaks moving away from the site. There's probably an infection, and you need to make sure that you're able to contact your provider.
Totally.
But I mean, the rate of infection on skin biopsies is so low that we don't see it very often.
Totally.
So the healing timeline kind of varies on where on the body the biopsy is taken.
Totally. Lower legs definitely going to take a little longer to heal, and I try to warn my patients that the legs, especially if you're prone to swelling, things like that, it's going to take a little bit longer than other areas like the face or like the arms or things like that. But yeah, it usually takes about 2 weeks to heal completely, or at least to seal over completely. But I get a lot of questions about how to manage scars on after a biopsy. And just like how you explained, the best thing to do is Vaseline every day. And then after about the first week, when it's starting to heal up and in, you're not getting that white exudate anymore, I'll have my patient switch to silicone, especially in cosmetically sensitive areas like the face or the ears or somewhere like the chest, if they're going to be showing upper chest or anything like that. But do you have any other tricks that you tell your patients?
Yeah, keep it protected from the sun. If you want to minimize the appearance of scarring, you're going to get some of that redness, that post-inflammatory hyperpigmentation. If sunlight hits it, it's going to get darker and it's going to last longer. And so you've got to keep it protected from the sun. And that's why in the clinic we carry a scar gel, but also a version of the scar gel, the Flawless Sun Shield, that has SPF in it. And we'll have links to those on the podcast show notes today to our scar products because they're really excellent.
Yeah.
In some cases, we actually did a study for the lab where we were putting the silicone scar gel directly on top of stitches after Mohs.
Oh, yeah.
Instead of Vaseline, and they healed great.
Really?
So keeping it protected from the sun's another thing to help minimize the appearance of scarring.
Yeah.
And then just know that they're going to keep looking better in most cases. If we're doing a larger shave biopsy on the back, sometimes those do look a little ugly just because of the tension on the chest, particularly of a female. They can look a little ugly. So sometimes we do a punch biopsy instead or an excisional biopsy. But keeping them protected from the sun, giving it 6 months, they tend to look better and better over time.
Yeah. In mobile areas like the neck, upper back, or things like that, I try to say limit movement as much as you can because the more you're pulling and stretching, it's going to pull that area apart. But it's hard. We have to live our lives and just understand that if we do a biopsy, there probably going to be a little discolored scar. But
yeah, in most cases, you've had a biopsy done. You want to know what the results are.
Yeah.
You've waited a week. You've waited 2, whatever it is. Different practices do it different ways. If you want to walk through the way that we tend to deliver results to patients.
Yeah. So typically, if you have a non-melanoma type skin cancer, and we will send you a text letting you know your biopsy report is ready. Call us at your convenience. And we typically will do that to try to avoid the phone tag that often happens where I've worked at offices where we call, we don't answer, they call, and we're busy and I can't deliver the results, and it just kind of gets messy. But we have usually someone dedicated to answering phones and reporting on the reports so that way when our patients do call, we can get them the answer as quickly as possible because very often they're calling and they're a little bit anxious about the report. So we try to get that to them very quickly. And then if it is a melanoma diagnosis, then we will call them and I personally will deliver that news, walk them through anything that they, what are we going to do about this, go over our expectations, and then answer any questions that they may have just because that can be a little bit more scary diagnosis. But very often we catch melanomas early, so that's the good news.
Yeah, same, process, no surprise, we're in the same practice. So rash results, hair loss results, anything that's not a melanoma or a potentially lethal skin cancer, those are just given by medical assistants over the phone. The treatment plan is discussed because we sign off those biopsy results often with very detailed instructions that our medical assistants should share. When I sign off a melanoma, I say, this is the result. Let's schedule a time to call the patient together.
Yep.
And so I deliver those results over the phone. There's been some cases where the patient's already got a return appointment, and we'll give them the results in person. Like if it's been 2 weeks and we're taking out a stitch, I'm just going to go over the results. Or like, oh, the patient's coming in tomorrow, so let's just wait till tomorrow to tell them. But if it's not, going to impact their care to wait a day, obviously I'm not going to be like, oh, it's a melanoma, I'm going on vacation, I'm going to come back in a week and then call the patient. Like we don't do that.
No.
Now, some practices do it a little differently. When I was in residency, we had such a large clinic that they kind of took the approach, no news is good news. And so if a patient had a result that turned out to be benign, they didn't call them.
Yeah.
And we've always taken the approach in our practice that we personally, as a practice, let every patient know their result, whether it's good or bad.
Yeah.
Because we want to be able to sign off in the chart that we've closed that loop. We won't ever have a patient out there wondering, oh yeah, I had a biopsy taken, I wonder what that was, and I don't have a return appointment for a year. And we like to make sure patients know so they can go about their lives. They don't have to worry about something. Some patients are very, very anxious, and they'll start calling 2 days after the biopsy, like, did you get them? Did you get them? And they'll call every day, and I'm like, sorry, they're not in yet. Doesn't always come back in one day. So at least if you're seeing us, Austin or I, or anybody else in the practice, you know your biopsy results every time. We also make them available on a portal that patients can access. And so you can log on and then you can read your own pathology result. And we're always happy to print a physical copy of your pathology result when you're in for an appointment if you would like that.
Yeah.
So
one thing that I realized early on is everything has a name, and if you don't know what it is, it can be confusing to the patient. There's always that little nag in the back of their head. What was that? And like in Harry Potter, Dumbledore was never afraid to say Voldemort's name. He was never scared of it. So we don't fear things that we know often. And so that's why I think it's important. And I like that we do that in our practice where we tell them what it is no matter what. Because there are many times where I've had patients come in, from out of state or other practices where they say they've had a biopsy done. I say, well, what was it? And they said, I don't know.
Yeah.
And like, was it a mole that they biopsied? I think it was a mole, but they didn't let me know. And I was like, okay, well, it's good to just let them know it's a benign mole. Because even then, if they're moving somewhere else, going to different practices, they can say, I had something removed, it was this, and it's benign. And that helps other providers tailor care to them as well.
Yeah. I've also had the experience where the patients don't know, and a new patient comes in and they'll be like, yeah, I used to see this dermatologist in another state. And I'm like, oh, any history of skin cancer? And they're like, yeah, I've had like 15 melanomas. And I'm like,
yes, I get that all the time.
Okay. Well, I need to review your charts. And then it turns out they had some atypical moles or they had a basal cell.
Yes.
So I like to make sure then I will take the time to educate the patient what they actually had.
Yeah.
So that, some of that can impact if they're applying for life insurance and they think they've had 15 melanomas, they're going to get rejected for life insurance.
Yeah,
so I like to make sure you did not have cancer in this case, or like you did and it's treated, it's been 5 years, you should not have any problem getting life insurance or disability insurance or whatever.
Totally.
So I'm a stickler for making sure you know what you got. What is the difference between an atypical mole versus a normal mole versus a melanoma? That stuff's important to me. So, and hopefully our patients that come in, they get that impression from us. Yeah,
so I would hope so. But we get a wide variety of emotions with patients. We get patients who come in and they say, just do the biopsy, doc, and just get rid of it, just do it. I know you're going to biopsy something. There are those patients, but then there are patients who come in and when you say the word biopsy, you could tell they start sweating. They're not hearing anything you're saying after that. And so it is important as clinicians, I know you do this, I try to practice this as well, where we read our patients well. If we see that they're concerned, it is important to take time, talk about what we discussed today and go through it simply with them. This is what we're going to do, because there's a wide range of people's emotions when it comes to doing a procedure on their skin.
Yeah.
So.
And we try to bring that empathy to every encounter and make sure that our patients feel that every time they come in.
Yeah.
So, or any communication we have with them over the phone. So all of that is to be said that we want to help you diagnose things as early as possible because treatment is going to be better, whether it's a skin cancer, whether it's a rash. The earlier that we can get the most accurate diagnosis, then we can help the patient have the best outcome possible.
Totally.
So don't be afraid of a biopsy. If you have a good relationship with your provider, you should know that they're only going to do a biopsy when it's absolutely necessary, and that sometimes you have to find another provider if you don't feel that from the person that you're going to. And it's okay to get second opinions. And I've had patients come to me for a second opinion, and I'm like, yep, I agree with your previous doctor. We need to biopsy, or, I'm comfortable watching this. And, I don't expect you to come back. You can follow up with your other provider. Thank you for getting a second opinion. I'm never upset when someone gets a second opinion after I've told them something. Mm-hmm. So my wife will tell you I'm not always right about everything. So. But I am pretty darn good when it comes to dermatology.
That's good, yeah.
But we appreciate you guys joining us on this episode. For our product of the week, as I mentioned, we're going to have the silicone scar gel and the flawless sun shield, our scar gel with SPF, as the products available in the podcast show notes. And a little update on the telehealth that we talked about on a previous episode. So previously, I was available for telehealth appointments in Idaho and New York. We can add Utah to that list as well.
Awesome.
So if you're listening from Utah and you'd like me to evaluate any skin concerns, send in prescriptions, you can do that by clicking the Future Clinic link in the podcast show notes.
Yeah. And you can probably tell them, hey, you need a biopsy of this thing, go see your dermatology provider.
Yep, I can't do a biopsy over telehealth.
Yeah, unfortunately.
So, well, we appreciate you guys joining us. We would love to hear from you. Send us a message on Instagram at skinfluence_pod. We'd love your feedback on your favorite episodes or questions you have that we could bring up in future episodes.
Yeah, we'd love to hear from you.
Thank you for joining us. Leave us a 5-star review wherever you listen. Follow us on socials, and we'll check you guys out next time.